depression, then in fact it becomes non-selective, right? Because you need to use higher concentration. This class of drugs are not very popular because toxicity and major food and drug interactions. The major food and drug interactions, many of the fermented drugs that they can turn in during fermentation, if there are phenylalanine or tyrosine in the protein, they can be turned into tyramine, and then tyramine needs MAO in your gut to be degraded. If your MAO in the gut is inhibited by the drug, then you have a lot of tyramine built up in your body. And tyramine is can act on the noradrenergic receptors. So it is a very powerful sympathomimetic compound. Therefore, it has hypertensive crisis, all of these effects. Okay, so that's pretty bad. And as Dr. Emmett said, that cheese, yogurt, white wine, some of those things. I was surprised that raisin also has a lot of tyramine, sauerkraut, and soy sauce. So those are important things. If one is on MAO inhibitors, those you should be very careful in having them. And then also MAO is involved in metabolism of many drugs if they have a primary amine, something like that. So then MAO would be affected, would be needed to metabolize them. If you inhibit MAO, you would cause excessive amount of that drug. Okay, so that's all I'm going to talk about MAO inhibitors. It's not a very popular drug for antidepressant. The second class I want to mention is serotonin norepinephrine reuptake inhibitors. This is SNRI. And then the first subclass is the tricyclic antidepressants, or TCA. So the TCA works at here. It blocks the reuptake of norepinephrine by the norepinephrine transporter, as well the reuptake of serotonin by the serotonin transporter, SERT. But in addition to that, the TCAs, as Dr. Emmett already mentioned, are relatively dirty. They also block other receptors. On this graph, it shows that it also blocks an alpha-1 receptor. Okay, but in fact, in addition of inhibiting the reuptake of norepinephrine and 5-HT, this is a whole class, also can block alpha-1 adrenergic receptor, muscarinic receptor, and histamine receptor, and then you can immediately derive the potential adverse effect of these drugs, right? So they are effective, but because they can cause serious side effects, they are typically not used as the first-line treatment. And these other key drugs, and then you can see that these three guys are tertiary amines, and then this one is a secondary amine. I always thought that when I see them, I thought that looked like a shark. Is that hammerhead? Hammerhead shark? Okay, good. So these are the common features of all of the tricyclic antidepressants. They have a low therapeutic index which means that at slightly higher concentration, they get into major adverse effects. Because they block the histamine receptor, so they can cause sedation. They block the muscarinic receptor, so they can adult cognitive function. Acetylcholine is very important for your normal function, to think, to pay attention, to learn. And then also because of cholinergic receptors are involved in the parasympathetic nervous functions, so you will have all these standard anticholinergic side effects. By blocking the alpha receptors, there is also static hypotension because blood vessel contraction require alpha adrenergic receptor, and also sedation. And very importantly, as Dr. Emmett had mentioned, that these guys actually also block a sodium channel. Therefore, it would affect action potential initiation. And so this quinidine-like, and it can cause arrhythmia. So cardiovascular adverse effects are a major, major concern. So be very mindful of that. And anytime you mess up with serotonergic receptors, weight gain also is something to pay attention to. Okay? So I just want to use one of these compounds as an example. So amitriptyline is one of the TCAs. Its indication is for relief of symptoms of depression, and then you can read all this. Again, just want to mention that therapeutic lack, adequate therapeutic effects may take up to 30 days to develop, okay? Adverse effect, you can see the previous, but for this class of compounds, withdrawal symptoms also something to pay attention to. If you abruptly stop the drug, it may produce nausea, headache, and malaise. If you slowly stop the drug, then it could produce irritability, restlessness, and dream and sleep disturbance. So how you stop it? I don't know. Okay, so there are contraindications. So MAO inhibitors and recovery phase of myocardial infarction. Okay, next class. So we are from less specific to move to more specific. So again, it's serotonin, norepinephrine. And then, so the new generation of the serotonin norepinephrine reuptake inhibitors. So as Dr. Emmett mentioned, the newer generation, the main advantage over TCAs are the fact that they don't talk to the other receptors as much, okay? So they are relatively specific to block the reuptake of norepinephrine and serotonin. So they work at the same site as TCA to block norepinephrine reuptake or serotonin reuptake. They do not block the alpha receptor in this graph, okay? So the SNRIs are relatively specific. So they are very beneficial in severe depression. So I just want to use one drug as an example, Cymbalta or duloxetine. So it is more potent for the 5-HT reuptake than norepinephrine reuptake. And then there are also two other drugs. And these two other drugs are primarily inhibit 5-HT reuptake at lower dose. But at higher dose, it can start to block norepinephrine reuptake. And even at higher dose, it can block dopamine reuptake. Therefore, it can improve all three. But by doing that, this can affect blood pressure. So it can dramatically increase blood pressure. So the two-letter drugs at high enough concentration, there's hypertension is a concern. So the adverse effects, they are relatively free of antihistamine, anticholinergic, and anti-adrenergic properties. So that's a major improvement upon the TCAs. So they have a higher therapeutic index than TCA, and of course, MAO inhibitors. These are some of the other side effects, but these side effects are also sharing with SSRIs. And when you touch serotonin, some of this just cannot be avoided. And then, as I mentioned, venlafaxine and this analog at high enough concentration that can cause a sustained diastolic hypertension. Very high for weeks. Okay, as I said, I just used duloxetine as an example. It is approved, so Cymbalta is very famous. You see it in television a lot. Its approved indications are several. The first two are related to mood and anxiety. The next three are actually related to its pain management, okay? Because, as I mentioned, serotonin system is also involved in modulating how the conductance of pain, as well as how we react to pain. So serotonergic drugs could be useful in pain management. So all these are pain management. So these are all standard informations. Okay, so the next class of selective serotonin reuptake inhibitors, SSRIs. These are the most popular drugs for managing depression. So they are first-line treatment. So where do they work? They only work on here. They only inhibit serotonin transporter. They do not work on the NET, or that is relative. So it's maybe if you increase the concentration 100-fold, then they will start working on others. But primarily by inhibiting the SERT transporter. And so it takes 100-fold more selective relative to NET. So because of that, so they have a much higher therapeutic index, much better tolerated in early therapies. So they are equally in efficacy in the prototypical class of drugs of TCAs. So there's some of the key features of SSRIs. They are favorable adverse effect. So just remember that they are overall very well tolerated. So it's not bad as TCA or MAO inhibitors. So there's no CV cardiovascular side effects, generally free of anticholinergic. There's actually one exception. And then there are no blockade of histamine or alpha adrenergic receptors. So wonderful. There are some adverse effects, even though I highlight them. They are generally well tolerated, but some of the things that you need to pay attention to. Weight gain, neurological fall. Neurological falls is that some of these drugs actually have extrapyramidal symptoms, the EPS. They actually affect that. So the patients might actually do not walk as well, and hence they would have a fall. So that's the neurological falls. By affecting the brain 5-HT receptors, sometimes insomnia, irritability, anxiety, decreased libido. By stimulating of the 5-H2 receptor in the spinal cord, erectile dysfunction, and orgasmia, you can understand what it means. A lot of work without the joy. Ejaculation, delay. And then for both the brain and peripheral 5-HT3 receptors, many nausea, sometimes diarrhea, emesis. Sudden withdrawal syndrome, if you suddenly stop it, then all these concerns. So even though I mentioned all this, I put them on red, I just want you to know them, but overall they are well tolerated. I want, as Dr. Emmett already broadcasted, I'm going to talk about serotonin syndrome, so or SS. So it is a very rare, but if it occurs, it can be lethal, can be fatal. So you need to know that. Anytime, no matter what drug class, no matter what disease you are treating, if you increase serotonin too much in brain and also in the periphery, you can cause the SS might occur. So some of these drugs that we talk about today, but amphetamine and neuretics, they can also stimulate the release of serotonin and therefore cause that. So there's a triad of symptoms, 3 of them. Mental status change, agitation, restless, confusion, unconsciousness. Autonomic instability, tachycardia, hypertension, like sympathetic nervous system increase. Dilated pupil, heavy sweating, fever.